Hello, everyone. Thank you for coming. Welcome to NAHDO's 40th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsors. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find more information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win prizes in the daily drawings. Now, let me turn the stage over to Norm Thurston, NAHDO's Executive Director. Norm, the stage is yours.
Oh, thank you, Debbie. It's so wonderful to be here with so many people today. See all of our friends with us. So I'd like to just introduce today our moderator and organizer, Katie Martin from HCCI, who is one of NAHDO board members. So Katie, go ahead. Charles, go ahead and bring Katie to the stage and I'll leave it up to you.
Good afternoon, everyone. Thank you so much, Norm. It's great to be here. As Norm mentioned, I'm Katie Martin. I'm the president and CEO of the Healthcare Cost Institute, and really excited to be with you today to talk about for the second Igniter session, which is focused on the impact of non-compete agreements in healthcare. Our session today will be led by Renee Greenawalt and Jake Muskovitz from the Pennsylvania Healthcare Cost Containment Council. You can find their bios and additional information if you just scroll down on your screen. So without much further ado, why don't we just go ahead and dive right in, and I will hand things over to Renee to kick us off.
Welcome to our Igniter session on non-compete agreements in healthcare. My name is Renee Greenawalt. I'm the Deputy Executive Director at the Pennsylvania Healthcare Cost Containment Council, commonly referred to as PHC4. Joining me today is Jake Muskovitz, our Head of Special Projects and the lead researcher for this study. To kick things off, I'd like to share a quick story about how PHC4 became engaged in this effort. On July 1st, 2024, we were asked for feedback on draft legislation aimed at establishing the Fair Contracting for Healthcare Practitioners Act, which prohibits certain non-compete clauses for healthcare practitioners in Pennsylvania. Included was a directive for PHC4 to perform a study on the effects of the act and to report our findings within 3 years. After some internal review, we responded that PHC4 could conduct the study, provided it was based on data that we had the legislative authority to collect. Just over 2 weeks later, on July 17, 2024, the legislation passed and the law was enacted. We then dedicated the subsequent months to gathering input and guidance from legislative staff regarding the anticipated scope and intent of the study. Following those initial discussions, we began preliminary exploration of ideas on how to approach the work. Next, I'll provide a brief overview of PHC4 before Jake delves into our study in this two-part video series. We'll be happy to address your questions after each of the 2 videos has concluded. PHC4 is an independent state council dedicated to collecting, analyzing, and reporting data aimed at enhancing the quality of healthcare while restraining costs within the state. Next year will mark PHC4's 40th anniversary, having been established by the Pennsylvania General Assembly in 1986. At that time, the Commonwealth faced double-digit increases in healthcare costs. The primary objective was to equip purchasers of healthcare benefits, such as businesses, labor unions, and other key stakeholders, with actionable information to improve quality and to manage costs. While transparency was not a prevalent principle in 1986, PHC4 has since become a recognized national leader in public healthcare reporting and a strong advocate for transparency. We operate with a small staff of 22, and in accordance with our enabling legislation, which outlines the 30-member council composition to include healthcare purchasers, insurers, physicians, hospitals, nurses, quality improvement specialists, consumers, and state government. The council also benefits from the expert insights provided by its various committees and groups. PHC4 is committed to continuously advancing our value proposition through regular evaluations of strategic objectives and program initiatives. Earlier this year, our latest strategic planning effort culminated in the council establishing goals within 3 primary focus areas: quality and payment data, governance, and communications and education. I'm pleased to share that we are making significant strides towards these goals with several already accomplished. In the area of quality and payment data, we published a new report just a few weeks ago on September 18th, showcasing the volume of 10 commonly performed outpatient procedures. We're also working on a new tool designed to aid hospitals in the verification process necessary for evaluating physician-specific volume and outcomes. Finally, we're preparing to start collecting additional payment data from facilities next year. Looking ahead, once we have sufficient data in these areas, the Council will pursue the efforts necessary to have results incorporated into our public reports. In governance, we facilitated opportunities for more strategic discussion, setting aside 2 meetings a year for the purpose. And in September, this time was focused on the comprehensive and thoughtful process involved in the conceiving, developing, reviewing, and presenting PHC4's reports. Furthermore, as shown on the slide, PHC4's council and staff collaborated to develop an updated mission statement, along with a vision statement and a tagline. In communications and education, our presence here today exemplifies our commitment to the council's objectives of raising awareness about PHC4 and enhancing our outreach efforts with stakeholder engagement. Wrapping up, I want to point out that PHC4 collects approximately 5 million inpatient and ambulatory outpatient records annually from hospitals and freestanding ambulatory surgery centers across Pennsylvania. This data is utilized to support our comprehensive public reporting and for special requests and purchases. Ours is among the timeliest population-based data accessible, with discharge information often available within a year of services provided. This information is invaluable for various research, policy, and analytical purposes. We encourage you to explore the data products and services offered through the special request process, which is detailed on our website at phc4.org. Now let's hear from Jake, who will provide insights from our study on the impact of Act 74 in Pennsylvania.
Thanks, Renee. To introduce non-compete agreements as they function in healthcare, we start with a real example of a pediatrician's non-compete agreement provided to PHC4 for presentations. This agreement reads, the doctor expressly agrees that for a period of 2 years, 24 months following the voluntary or involuntary termination, the doctor will not do, perform, or participate in any manner of engaging in the business of selling same-type pediatric medical services within a 20-mile radius of the practice address. In this agreement, we see an outlined time period, the inclusion of involuntary termination, specialty-specific language, and a geographic radius. With the enactment of Act 74 of 2024, non-compete agreements were limited to a 1-year maximum and only enforceable if the practitioner leaves voluntarily. Under Act 74, practitioners dismissed for cause are released from their non-compete agreement. This legislation only applies to medical doctors, doctors of osteopathy, physician assistants, certified registered nurse practitioners, and certified registered nurse anesthetists. Now that we have an early understanding of the changes present in Act 74, we're going to look at the last 2 sections. The penultimate section of Act 74, Section 6, mandated a study be conducted by PHC4 with reports due to the chairs of the respective health committees in each chamber of the legislature. The Act did not provide PHC4 with direction on what to include in a study. Additionally, the Act did not provide PHC4 with the funding to construct new data collection methods, nor the authority to compel stakeholders to participate. Our first clue to which topics in healthcare are of interest to the members of the legislature mandating the study came from Section 2 of Act 74. I have summarized the 8 points laid out in the legislative intent section with their topics. The actual language is longer than what is shown here. The highlighted topics are the ones that PHC4 was already contributing research to or planning on contributing to in one form or another. So we were able to build off some existing work and some familiar topics. You heard from Renee earlier about our 5-year strategic plan and the efforts to expand the audience of PHC4. With the establishment of this study, we took an opportunity to serve the goals of the council and the legislature in a couple of ways. Our first effort was to write a current events article to draw attention to the topic amongst our current audience and to build excitement for our study and to bring new audience members into the fold and expose them to the rest of our work. As the study has progressed, we've pursued speaking opportunities at the Pennsylvania State Boards of Nursing, Osteopathic Medicine, and Medicine. We spoke to faculty members and graduate students at Drexel University, and of course, we're speaking to you all here at NAHDO's 40th Annual Conference Igniter session. I hope you enjoyed part 1 of this 2-part video series. Before we take a look at the data sources and the methods we've employed so far in our study, we'll pause to answer some of the questions you may have.
Thanks so much, Renee and Jake. It's a really helpful overview of the project. Charles, is it possible to see if we have any questions at this point, or if not, we can just move to part 2.
So now we'll be getting into the data sources and methods in this study. Unfortunately, we don't have time to cover all of them in equal depth, but please feel free to ask questions at the conclusion of this video about any of the data sources. This is a slide we'll be returning to as we discuss the 6 categories of data currently supporting this study. Our first data collection effort was a public comment period that ran for a month. We've been training both human-driven and automated models to interpret themes expressed in the comments we received. A few months before Pennsylvania passed Act 74, the Federal Trade Commission issued a final rule banning non-compete agreements that would go on to be struck down in the court system. In deciding the rule, the FTC collected over 26,000 public comments. We were able to identify 5,185 comments within this sample that related to healthcare, and 176 of those mentioned Pennsylvania specifically. Using this sample, we trained a thematic analysis model. Our model identified 48 unique themes in this dataset, shown here as clusters on a scatter plot. We applied this model to the comments we collected specific to Act 74. We plan to open a second comment period in early 2027 and to apply this model to those comments to measure any changes we observe over time. This graph shows the count of themes by sentence from our Pennsylvania public comment period. Almost every comment discussed patient access to care in one manner or another. From there, commenters diverged on their topics, and some of the most common themes are visualized on the x-axis here. The second data source we'll discuss is the first iteration of the hands-on care provider survey we ran. We hosted this SurveyMonkey on our public website and directed providers to fill it out voluntarily and without compensation. We plan to run this survey again in early 2027. The website page received 2,239 views during the 3-month window it was open. Of these total views, we recorded 439 survey responses, a response rate of 18.9% compared to total views. We offered 2 versions of our survey, basic and expanded, and we invited respondents of our basic survey to optionally continue on to our expanded survey. 36% of respondents chose to answer just the basic survey, but by the time they reached the end, 81% of those respondents had more to say and chose to continue answering questions. In our conversations with providers since the survey closed, many expressed a willingness to answer even more questions and have provided valuable feedback for additional questions and data points to collect in the second round of this survey. The next 2 slides will provide a brief look at some of our early results. Importantly, this data is not generalizable to a larger population due to the limitations in setting up the study. This two-way table shows a respondent's employee status in the first column and whether or not they are bound by a non-compete agreement at the time of the survey response. Some of the responses were excluded from this early result in preliminary cleaning of the data. Over half of survey respondents were employees currently bound by an active non-compete agreement. The survey optionally collected zip codes from respondents for their home and their primary practice location. These zip codes have been visualized here on a map. Respondents who filled out both the home and primary practice location zip code fields are shown here connected by a dotted line. The legend in the lower left shows the colors of these lines to note whether the respondent has an active non-compete agreement. Due to the higher concentration of providers in the more densely populated areas, the yes respondents are visually covering some of the no and unsure respondents. However, we saw on the previous slide that yes was the most common answer to our non-compete question. As you take another second or two to absorb the data on this map, I'll mention again that due to our study limitations, There is bias present in the collection of these survey results. These locations or concentrations are not generalizable to the larger population of healthcare practitioners. Our third data source is the National Plan and Provider Enumeration System. We download a public nationwide file each month from CMS. From these numbers, we can identify practice locations of Type 2 NPI numbers specific to facilities. The tracking of filed civil lawsuits was a suggestion we received from the legislature. They wanted to understand if non-compete agreement disputes were burdening the court system in Pennsylvania. Pennsylvania has a cover sheet, which is the only consistent document present in every civil lawsuit. We are interested in identifying contract lawsuits that fall into the categories employment dispute other and more generally other. Our efforts in collecting data on these cases are very much ongoing, but our goal is to identify healthcare entities and the names of the plaintiffs and defendants. This map shows the Pennsylvania counties in green that we have so far been able to obtain records from. These 67 counties use 19 different data vendors. Nonetheless, we've been able to identify 8,075 unique case participants, including 39 individual physicians from just over 5,000 cases so far. From Pennsylvania's Department of Health, we've accessed public facility reports, which are published yearly for each hospital, ambulatory surgery center, and nursing home. One of the data elements contained in these reports is a count of the medical staff by license type with active clinical privileges at each hospital in Pennsylvania. The graph shows the license types identified explicitly in Act 74. The x-axis extends out to the end date of our study. MDs and DOs have been combined into the physicians category for simplicity and visualization. The most recent data available is 2023. The Hospital and Health System Association of Pennsylvania, known as HAP, has supported PHC4 in conducting an employer-focused survey tailored to the specifics of the hospital industry. Survey data collected from hospitals can be clustered and joined with PHC4's routinely collected financial and clinical data to provide further insight into the impact of this law. So, our ask of you for having been such a good audience today is to get in touch if you know of any way you can support or contribute to our study. I've included my contact information here. We're particularly interested in finding other states to use as counterfactuals for comparison against what we're seeing in Pennsylvania. If you believe your state can serve as a comparison, or you know of any data sources that match one of those described here today, please don't hesitate to get in touch. In conclusion of our video, we'd like to invite you to stay up to date with everything we're doing at PHC4. From left to right, you can access our newsletter and Contact Us page, our public reports, and our case studies, which are short write-ups of some of the work done by others using PHC4's data. Thanks for your attention. We at PHC4 hope you found this presentation interesting. We want to say a quick thank you to NAHDO for putting us up on their stage to talk about our work. In particular, thank you to Norm Thurston and Charles Hawley for supporting us and appearing in front of you all, and thanks to Katie Martin for moderating this session. We look forward to hearing your questions and comments.
Great, thank you. What an interesting and informative presentation. Thank you both. If folks could add questions to the chat or in the online, we would love to hear kind of what's on your mind. I know we have one already, but I thought I would maybe kick us off with sort of a more general question. Studies like this are really complicated, as are most healthcare studies, but in particular, trying to study the impact of one specific element, in this particular case, non-compete agreements, when the outcomes that you're looking at can be influenced by so many other things going on in the healthcare system. Can you speak to that challenge, the challenges of studying the impact of a singular element within the broader landscape of ever-changing healthcare system?
Yeah, pardon me. Thank you. I'd be happy to. It's a great question. And as our healthcare system continues to change, the idea of teasing out the specifics around one particular element, like a non-compete agreement, it has been challenging, to say the least. I'm going to touch on two specific outcomes in particular that we heard from our public comment period. The first one being improving physician dissatisfaction or burnout. There was a mention in our comment period that limiting non-compete agreements might reduce the feeling that physicians and other healthcare providers have of feeling trapped in their jobs, and that this could help alleviate some of the dissatisfaction and the burnout. The challenge with this, as we've come to know over the years of more discussion around healthcare provider burnout and dissatisfaction, is that non-compete agreements are one small piece within all of these other changes, and identifying the magnitude or the scale at which the non-compete is contributing to something like an individual person's dissatisfaction or a population's dissatisfaction at large is certainly very challenging. On the other side of it, we heard in our comment period about a couple of outcomes saying this legislation would hurt hospital staffing. This is a similar piece, that non-compete agreements are just a component, definitely involved within efforts to staff places of healthcare, but only a small piece, especially in the wake of the pandemic that this country has just lived through, letting a bunch of the healthcare staffing find a new normal and stabilize again, makes it really, really challenging for us in the time frame that we've been given to analyze the impact of changes in non-compete agreements, especially given the fact that this legislation very potentially has much longer term impacts than just the time frame in which we're being asked to study and report on those findings.
Great, thank you. There's a question in the chat about using the automated model that you used. You mentioned a bias towards making your findings or hindering your findings being generalizable. Do you include a disclaimer identifying the potential sources of that bias?
Yeah, thank you. So the public report is still very much in draft stage and isn't due until January 1st of 28. But one of the tallest tasks that we'll have in communicating our findings throughout this study is acknowledging bias and limitation where it's present. There was reference to an automated model, and so I think there's a small piece of miscommunication. The automated model for the public comment period was applied to a large national data set of comments in a hope to pull out themes without as much bias from human-driven analysis. That model is then being applied to comments that we received specifically to Pennsylvania and plan to collect a second time in 2027 to see how the outputs of that model might change over the course of our 3-year study. The sources of bias that I talked about in that second video come from our collection methods, particularly around the surveys. Without the ability to compensate survey respondents for their participation and favoring the pragmatism of our study, we cast as wide a net as possible in the hopes to get as much feedback as we can, understanding that when you invite voluntary participation for something like a survey, your results bias towards the participants who feel more strongly about it. You tend to lose the people who are in the middle of the range, and you get both of the extremes. And so we're aware of that. This is a resource-strapped study, and we're doing the very best that we can. And as it comes to disclaimers, again, much of our report towards the legislature in 2028 will include language around acknowledging bias and the steps we've tried to take to address that.
Great, thank you. Just another ping for the audience to throw any questions you may have into the chat. While we wait for that or wait for additional questions, can I ask a little bit about the data sources? You have that slide with a number of data sources on it, and obviously you're pulling data from everywhere that you can. You sort of alluded to the resource limitations you're operating under. So as you embarked on this study, how did you think about and evaluate the merits of those various data sources, and how did you pull the right combination of data sources to be able to answer the question that you were pursuing?
Absolutely, thank you. So the merits of the data sources, the pros and cons, as we've tried to think through what's available and what's of value to our end report, it's been driven again a lot by pragmatism. I might hit this once or twice more as questions keep coming. The effort to use data that we could access easily and for free or with a low cost through a collaborating stakeholder partner of ours has really been much of the bulk of our effort. The pros of this, as I mentioned, are we're trying to get as much information as we can that might have some piece to tell about this story of non-compete agreements. None of these data sources are a silver bullet with a clear answer, yes, this is the impact of this legislation. And so we're trying to set up a bunch of things kind of around the topic in the hopes that we can really understand some of the impacts, more looking at symptoms than necessarily being able to measure something all the way underneath. The combination of our sources, I really appreciate this question because we at PHC4 are a nonpartisan organization. We were established by the Pennsylvania legislature, and we have a governing council of members that come from a range of industries. And so it has always been an effort here at PHC4 to continue our nonpartisan standpoint. And in this study, we've made an effort to take a very balanced approach. And I'll touch a little bit more on the balanced approach. Through our comments, we heard a lot about what sounded like a labor market study interest. And so I'll describe that distinctly from a healthcare market. In a typical healthcare market study, you would talk about the patient demand for healthcare services, and patients would make up the demand curve on this economic graph, whereas healthcare providers would be the supply side. We didn't hear too much about a healthcare market. We heard much more about a labor market, in which case these healthcare providers or employees are the demand for jobs, and the facilities, the employers, the hospitals, whoever they may be, are the supply for these healthcare jobs. And so as we've taken an effort to combine these data sources, we've tried to develop metrics that are both supply and demand side metrics. And if we go out and collect something on the employee side, we're doing our very best to collect something at least analogous so that we can get as close to apples on the employer side, and in the end publish what is a balanced effort, a balanced report, something that did its best to take in and to report on the experiences of all the different stakeholders that have offered something to our study so far.
Yeah, great. It strikes me that so many of the data sources you're relying on are sort of atypical for what a healthcare cost study would be. What would you say has been the most surprising or creative data source or the most unexpected source of information that's been helpful for you as you've been moving forward?
Yeah.
Sort of I never thought I would wake up one day and need to look to X to get my job done today.
Right. I think what's been most interesting has been the approach towards the judicial side of things and the impacts on the court system. We, in some of our early conversations with the involved legislators or legislative support people, we heard that there was an interest as to whether disputes around non-compete agreements were being settled in-house. Maybe they never quite made it to the threshold of a civil lawsuit, or if there was a lawsuit, maybe they never quite make it into a court system. And we were curious, or we were asked if the prevalence of or the use of non-compete agreements in healthcare was ending up in the court system. And this has been a very fun challenge. And again, we showed a little bit of the map in the second video where Pennsylvania has 67 counties, and they use 19 different data vendors to report their data to a small research arm that exists under the Supreme Court of Pennsylvania. And just getting in touch with this small research arm and going, oh, you guys look very similar to us as a healthcare research organization. You have a very similar, reporting and data storage structure. It sounds like you deal with a lot of the same issues of cleanliness and access and, low resources and low funding. And so being able to interact with a similar organization to try and get data out of them in this topic was very, very interesting, especially when they sat there and said, we don't really have anything centralized and clean for you. You're going to have to go to each one of the counties if you want to collect this data yourself. And so that was not something that I expected right off the bat to be as nuanced as it has been.
Yeah, great example. There's another question in the chat about the second round of your survey and whether you anticipate making any tweaks.
We do. So we ran our hands-on care provider focused survey at the beginning of 2025. And as you're alluding to, we're going to open it again in early 2027. Some of the feedback that we received, especially during presentations much like this one, has contributed to the questions that we've included in our survey. And so this first time around, we looked a little bit at addressing more of the life experience aspect that non-compete agreements might impact for hands-on care providers, and decided to take a little more, and decided not to go that route. And then in conversations, and especially during our presentation to the State Board of Osteopathic Medicine, we received feedback that many of those questions to physicians and other hands-on care providers about whether it's feasible for them to take a year off from their job to let their non-compete agreement lapse and then go find another one, didn't get asked, and that they wished that they could. We mentioned a bit in our video that many people got back to us saying, hey, we would love to answer more stuff about this. And so there was interest in our surveys capturing more of the individual experience. From the employer side, we're going to try and take a bit more of a quantitative tact and see if we can collect information, or if employers will be willing to share information with us around the prevalence of non-compete agreements that they have at their organization, whether they're able to track costs like retention and recruitment and things that we heard might be impacted due to non-compete agreement changes, but still will take some time to collect and to develop. And so, I appreciate the question. There's a bunch of tweaks. And if any of this leads to ideas, hey, you should ask about this, please feel free to shoot me an email.
That's a good segue. We just have a few minutes left. So at the end of your presentation, you mentioned ways to get in touch with you and kind of things that you're looking for. How can the folks who are tuning into today's session support this study as it moves forward?
Yeah, thank you. As we had said at the end of the video, as I've said once, I'll say it again, and to the audience, please get in touch. We would love to hear from you. I have touched a couple times that pragmatism is driving this study, and so we're presenting to you what we have so far. We're about 2 years, and 2 months away from our final presentation of this report. If someone in the audience knows of a data source like, oh man, this is that silver bullet that you're looking for, please get in touch. I'd love to hear about that. Anything that gets shared will absolutely be considered for whether it adds value and it can be included in our report. Additionally, if anyone in the audience is familiar with something in their state that might have a similarity to something that we've been measuring or are interested in our state, one of the next steps for our process is to start finding these state-to-state comparisons to see if we can tease out any impact on Pennsylvania that wasn't seen in other areas. And much of that work is still early on. So if any of the audience has ideas around states that would be great comparison pieces, or data sources that are analogous and would be easy to wrap in with what we have, we would love for you to get in touch and just to leave a comment here on we would love for you to get in touch. And then just generally, if you have comments on how our presentation went, please feel free to reach out and to get in touch. We would love to stay in communication with as many people who heard us speak here today as possible. That'd be awesome.
Great. So it sounds like feedback on the presentation, but states and researchers who are doing similar work, who maybe have been through some of the same challenges and might have some inputs for you as you move forward. And then third, states that are maybe have similar laws or undertaking similar policy changes. I guess there are 4. And then the last but not least is data and available data, which is always a challenge and appropriate for this NAHDO crew. So if anybody has any ideas or suggestions, maybe we can, I don't know, Jake, if you want to calling an audible here. If you can, in the audience chat, maybe just drop in your email address for ease of reference. So all the contact information and everything will be available in the slides when those are available.
Yeah, be happy to make that available.
Great. Any last questions or comments for Jake or Renee? Okay, thank you so much. This was such an interesting topic. This is not something that we've dealt with a lot at HCCI, and I know that non-competes have been, as you alluded to in your presentation, really a topic of broad interest and broad discussion, but in particular, the impact in the healthcare community is really front and center. And so I will be certainly following the progress of your study very closely, and really appreciate you all taking the time today to share it with us.
We
Charles,
appreciate the opportunity.
Of course. Charles, you want to take us on home?
Yeah, just let me echo the same sentiment. Thank you all. And thank you everyone for being here today. I want to just share a little bit of information about what comes next. So join us next week, Wednesday, October 29th at the same time for our next Igniter series session with Danny Saunders from HSRI. Danny will share how the Maine Cancer Blueprint uses integrated administrative, clinical, and vital statistics data to increase awareness of cancer-related issues in Maine. So hope to see everyone there. Take care.